Julian, who is the specialist trauma paramedic, one of them here at Strencham. Also, we've got Dr. Katie White, who is a specialist trauma paramedic. Also, Colin Apps. We've got Grant Salisbury as well, and also Becky Chappell, who are new critical care paramedic trainees as well here at Strencham. So I'll hand you over to Julian. Thanks, Julian.
Hi there, welcome to Strencham. Thank you for coming on this what turned out to be a very, very well turned out day. So, welcome to you all. What we're going to be doing today is just running through the type of scenario, which is generally the bread and butter of what we do. We respond to traumatic incidents in the sort of West Midlands region, and the type of incident that you're going to see pan out now is kind of very, very common, happens on almost a daily basis with us as well. So what we've got here is our patient has fallen from height. They've fallen from the roof while they were doing something like cleaning the guttering out. We've had sorts of incidents of different types over the years, but this is the sort of thing that we would get called to on the air ambulance. So the crew will hear about this because we'll be mobilised by the West Midlands Ambulance Service. They'll call us. Okay, back with you. We do have comms problems sometimes. So the scenario here is the patient's fallen over 6 metres. No? Oh, yeah, okay. So they will have fallen and they are unconscious as a result of that fall. Now, this is the type of incident that we would get to flag to. The controllers would actually look at it and go, okay, this is quite a serious incident. The chances are that this person has been critically injured, and therefore we'll need to dispatch the helicopter as well. So, responding one of the 3 aircraft, the crew will actually attend the scene. We can be anywhere within the region within around about 10 to 15 minutes, backing up in support of West Midlands Ambulance Service as well. So the crew will arrive on scene. Sometimes they're not able to land very, very close, so they might have to make their way from wherever the safest landing site is, and they'll actually arrive at the scene.
No, just stand there and watch.
When they get to the scene, they'll actually make basically what we call a primary survey. So they'll be looking for any dangers to themselves as well, such as the ladder falling down on them. They'll make an initial patient assessment. So what they'll be looking is checking the airway, looking to see whether the patient's breathing or not, and checking for pulses. Okay, this gives us a good indication of whether this is a time critical job, or whether or not we've got a little bit longer that we can spend packaging the patient carefully. So Dr. White has gone to the head end there. She's actually making an assessment of the breathing, and Colin will be applying the actual monitoring equipment that we carry. So what she's actually doing there is actually making an assessment of the breathing, and has actually worked out that actually this patient isn't breathing satisfactorily. So what she needs to do is actually increase the breathing rate a little bit, just so that we've got enough oxygenation going into the patient. So what she's now doing is removing the clothing as well. Might sound a little bit strange, but we actually need to get down to skin level sometimes to find out what all the injuries are. So she's making a chest assessment now, just to make sure that actually this person has got the correct mechanism to allow them to breathe properly. She's not finding anything there at the moment. So she's going to, part of her breathing assessment will be to listen to the lungs and make sure that the air that Colin is squeezing in using the bag is actually getting through to the lungs.
Adam, lift your head up.
So moving on from that, she's now moving on to a circulation, just checking for any abdominal distension, basically finding out whether there's an internal bleeding going on as well. The patient's fallen from quite a height, okay, so there's a significant possibility that we could have a pelvic injury. Pelvic injuries are quite serious, and basically you can lose all of your circulating blood volume into your pelvis without actually showing any outward sign. So the second crew's arriving now. This is Becky and Grant. These are 2 of our sort of new CCP trainees. They've joined us, and they're on a bit of a sort of quite a tough year. They've actually got to do a critical care course and also learn to use all the platforms as well. So Katie's made the decision now that because the patient is unconscious, once they've got the patient packaged, they're going to do what we call an RSI, which is a rapid sequence induction of anaesthesia. So this is normally, traditionally this used to be done in hospital, but we've actually realised that there are neuroprotective benefits to actually performing this in the field and then taking them straight to the hospital. So what they're going to do is actually come at the patient from multiple angles now. They're going to be applying a pelvic binder which applies splinting to the pelvis area, and that will actually prevent any further hemorrhage. The patient has also got a broken leg as well, so they're going to put a leg under traction. Again, you can lose 1.5 litres of blood actually into a fractured femur. And what they're also going to be doing is Colin here is going to be setting up what we call a kit dump, which is all the equipment that's needed to actually put the patient to sleep.
A little bit.
It's fine, okay.
So as part of the kit dump that Colin's setting up is all the equipment needed, and he has to put it out in a sterile area. And one of the areas that we use are actually using the yellow bags. He's showing the laryngoscope there, so that's what that's going to do is actually put the tube into the patient's throat, as if you were having a real operation in hospital, but we're actually doing it pre-hospitally.
I'm going to do it, I'm going to kill you.
So Colin is showing you the endotracheal tube there. It's an ET tube, and what that's going to do is actually sit down into the patient's windpipe, and it will actually enable the cuff to be blown up, which will actually seal it off as well. At the moment, Grant and Becky have actually applied the pelvic binder, which is the blue belt that looks like it's sort of around the patient's waist. That's actually holding the pelvis together. And they're actually applying what we call a Kendrick traction device now, which is a nice new lightweight piece of kit that's come onto the market in the last couple of years. It takes the place of what was previously quite a bulky and heavy piece of kit, which means that obviously we can carry a number of them. So part of the RSI process is to actually just make sure that we've got everything in place before we actually do it. Obviously it's quite a risky procedure. It's not like in a hospital where you're actually giving an anaesthetic to a relatively healthy person. We're actually giving them to sort of critically unwell and sick patients, so obviously that has to be taken into consideration. So we tend to drill this quite heavily. We'll practice sort of fairly regularly. And we use lots of standard operating procedures so that we're doing exactly the same procedure in the same way every time as well. So the decision at this point basically is that because this patient has a possible pelvic injury and also a long bone fracture as well, they're also unconscious. So the chances are that what we'll be doing is taking them to the local major trauma centres. Major trauma centres in this neck of the woods are QE in Birmingham, the Queen Elizabeth Hospital, and we've also got Southmead in Bristol. We've also got Coventry over the other side of the region as well, and further north in our operating area we've got Stoke. For paediatrics there's even fewer of them. We've got the opportunity to go to Bristol or Birmingham, so they are quite limited on the paediatric front, but the kind of patient population that we normally see are generally adults. So what they'll be doing now is actually packaging the patient, actually moving them. Obviously there's a risk of spinal injuries and further injuries as well, which we don't want to aggravate by uncareful moving. So we'll be moving this patient actually onto a scoop stretcher, and then to actually do the anaesthetic we'll actually put them onto the stretcher there, which actually provides a nice safe operating area that we can actually sort of do that nice and safely.
Mom, should put there. Oh. Just give it me. Give it me.
So we've actually got an orthopaedic scoop stretcher there that they're actually loading the patient on as well. This is a lot more comfortable than the old way. We used to put them onto a very stiff board, but that was actually found to have much worse sort of tendencies to actually injure the patient more. So we actually use the orthopaedic stretcher now, which is actually a little bit more comfortable for them, and it provides us a safe enough platform to actually lift that patient from that position without actually aggravating their injuries any further. So what they're going to do now is actually move the patient to the sterile area so that they can actually perform the anaesthetic. Dr. White, as the senior clinician, will now sort of allocate roles to the individuals so that everyone is of an understanding. Good communications is key to actually making this whole process work and to actually us getting the patient safely to hospital. Becky's actually providing manual stabilisation there, which is actually just in case the patient has got a neck injury. It's important that we don't sort of aggravate that any further. The chances are they've fallen from over 6 metres, so there's a possibility that the injuries could be quite severe. So obviously as the pressure's on, the chances are that something might get missed, which is why we always resort back to the checklists, and that's what Dr. White's going through at the moment.
Stop, Lexi.
So what we tend to do is treat for the worst case scenario, which is that we're not going to be successful on the first time, and what we'll actually do is make sure that all the equipment is in place. So it might seem that this is wasting time, however, time spent in the preparation means that it doesn't go wrong and we actually get a first pass intubation. Okay, so the anaesthetic drugs are just about to go in. There's two elements that they're given here. We're actually giving a sedation to actually put the patient off to sleep, and then we're going to give a paralytic drug as well, which allows us to actually take over the ventilation of the patient, and it means that we can actually tailor the speed and depth of respiration just so that we can actually improve that patient's sort of like prognosis. So Colin's doing the intubation now. He's going to use the laryngoscope. He's going to look for a view. The airway assistants then are going to provide the bougie, which is the long blue piece of equipment. And what that's actually going to do is going to pop that down into the windpipe. And then once we can visualise it actually going through the vocal cords, what we'll then do is pop the tube on, and then we actually railroad the tube down through the bougie. It means that we get a definite confirmation of placement sort of fairly early on, which is what it's all about. Once that's in place, what we'll then do is inflate the little cuff on the bottom of the tube, and that will actually basically creates a barrier that stops any sort of like vomit or anything, any other fluid such as blood from actually entering the lungs. which can cause sort of like infection and problems further down the line. Once the tube's in place, we'll secure it off. And then what we can do is actually look to start packaging to leave scene here. And obviously, depending on where the hospital we're going to is, we'll make a decision as to whether or not we go via air with the aircraft or go by road. To save having to squeeze the bag, what we can also do is pop them on the ventilator, which allows us to give a more controlled actual amount of air going into the lungs. And it will also enable us to control the rate as well. So we're now actually breathing for that patient, and their actually heart is beating for themselves. So part of the issue we have as well is making sure, obviously we need to leave scene quite rapidly now, so we need to actually have somebody going around picking up all the equipment and making sure that we don't leave it at scene, because that obviously would affect our response time for the next job. And obviously a lot of this kit is very, very expensive. So the crew will be leaving scene now and heading off towards the aircraft. And that concludes the demonstration. So what they've done... So what you've seen there is kind of almost like a real-time example of what happens actually on the jobs. Obviously it's a little bit, you know, it is a scenario. It's not quite as simple in real life. There might be logistics to consider, like getting to the aircraft. But yeah, that's what we do on a day-to-day basis.
Give a big round of applause. I was going to say I'm going to put you on the spot. Right, we have a quick Q&A session. Has anybody got any questions? Anybody got any questions? Put your hand up and I'll come over to you. Anybody?
Right, come on then.
You got a question? Anybody got a question?
Adam, come on.
Have you? No.
Yeah, anybody got any questions, then please just talk to one of the crew, and hopefully the rain won't stay on too long.
Once again, ladies and gentlemen, big round of applause please for Julian, Katie, Colin, Grant and Becky.